great to be here with you all. As Lainey said, I did my postdoc with U of M and feel like I'm still sort of part of the Michigan academic community. I see some familiar names and faces, but just so I have an idea, for the folks who I don't know, could I get like what kind of where are folks coming to this talk from in their sort of training and work lives? Lainey, do you want to just give me like a overview?
Yeah, absolutely, of like who the audience is. Yeah, so we have some staff from our centers that are interested in this topic. We have a lot of trainees from our Michigan Youth Violence Prevention Center and the Institute for Firearm Injury Prevention. We also have folks here from the Injury Prevention Center and their trainees. So it's kind of like a three-pronged center talk series. And then we also invited some community members. So I think it's kind of a range of levels and audiences.
Thank you so much. Yes, you had told me that in advance. I just wanted to sort of check based on who here's today, because there'll be places here where I mention work out of University of Michigan that some of you may be familiar with, some of you may have contributed to or led. So please step in if there's anything I get wrong, but it may be helpful for those of you who are sort of in training. Maybe it'll be helpful to see that work contextualized here. I also want to encourage you to please jump in and ask questions as I go along, ask questions or respond. You can do that either with the chat or by unmuting yourself. There will be points where I ask you to jump in as I go along, just because I think that works well for these kinds of talks. And yeah, I mean, I think based on coming to this talk that I'll be talking about gun violence and including racial disparities in exposure to gun violence. Those are topics that can land differently with all of us for lots of different reasons. And so if there's any point where either you want to step out or if you want to pause the conversation and react to the presentation, I would encourage you to. So I will share my screen here. As Lainey mentioned, this is work that's supported by a career development grant from the NIH, the Institute on Minority Health and Health Disparities. My lab at BU is called the RISE Lab. You see some of my colleagues here. And so what I'll be talking about is one way of conceptualizing community gun violence and the factors that influence it. Really the goal of this talk is to show you some research that brings together person-focused interventions, place-based strategies, and an understanding of structural factors that might point us towards multi-level solutions that are commensurate with the problem that we're working on. So I'm sure you've had contact with this idea over the course of the summer or through your work. The idea of gun violence is a public health issue. This is a picture from our campus here at BU. And just a few of the statistics that could tell us about this problem. Gun injuries are now the leading cause of death among children and teens. And they're characterized, so this is a big public health burden, but it's characterized by huge racial and ethnic disparities. So for example, the black-white disparity in youth gun homicide in cities, you can see in this chart, rates of gun victimization around age 12 are still comparable between black and white teenagers in cities, but as they get older and enter the higher risk stage of adolescence, the rates of victimization among Black youth are much higher than white youth. And I mean, just to put this number in perspective, this is 20 times nationally. In the Boston area, it's more like 40 times. Just to put that in context, for some of the other health disparities that we understand to be extremely important and extremely severe, like, for example, maternal mortality or chronic diseases like diabetes, we're talking about disparity ratios of 2 to 1 or 3 to 1. And for youth gun violence, we're talking about more like 20 to 1. In a recent study, my colleagues and I found that in some major cities during the pandemic, child gun assault rates had ratios of, there was a 100 times disparity between Black children and white children, 26 times disparity between Latinx children and white children. And that's in part because disparities have worsened during the pandemic, or since the start of the pandemic. So this picture shows, I think, what continues to be the prevailing way of thinking about violence, and that's contrary to a public health approach. It's the idea that there are perpetrators and victims, bad people who enact harm on others. And this is understanding violence in terms of individual fault is one of the driving forces behind using the criminal legal system, police, courts, jails, prisons, as kind of the default response to community violence. And this is not the only place in public health where this comes up, right? Blaming individuals for behaviors that are conditioned and structured by a range of factors is prevalent across a range of health areas. So just pause for a second. Can you think of other areas where we tend to explain bad health outcomes based on individual bad decisions, individual level blame and fault? Substance use is a great one, and thank you for starting us, Sarah. Obesity, definitely. So for example, obesity, health outcome shaped that we ascribe to individual level faulty behaviors rather than things like the food environment, structural stressors, interpersonal discrimination. Sexual health, yeah, a range of sexual health outcomes, including HIV. Socioeconomic status, right? It's right. Poverty is ascribed as an individual's fault because it's possible if you work hard enough to escape poverty, ignoring all of the important structural barriers. Mental health problems, these are great examples. Homelessness, yes, and we can also now see sort of linkages across a lot of these outcomes that people are listing. So really important, right? And these are all problems where I think sort of in their own fields, folks have had to say, hey, like we need to look at this from a public health standpoint. And in doing so, we can move beyond this focus on individual level faults and blame to what's actually going to work. There's two reasons for that. The first is that individual level fault is an incomplete, often incorrect explanation of what's going on. And the second is that it doesn't work to focus solely on individual level choices. It's just not that we've learned across basically all of the outcomes that you all listed that just trying to change how individuals think and the choices they make is not sufficient in the face of all of the other factors that are being ignored on this individual focus outcome. So that's just to contextualize violence in terms of all of these problems. And actually, I would argue that compared to, like, even in the context of these really extreme examples that you all gave, violence is one of the areas, maybe the area, to which we ascribe ideas about blame and fault more reflexively, less sort of in less of a considered way. It's just built into the conversation that folks who use violence are at fault and need to be punished. But what research tells us, including research from the University of Michigan, is that at the individual level, the enactment of violence, the use of violence, is associated with past harms, right? So someone who, for example, in a research study, comes into the emergency department with a violent injury, we can see that downstream, they are more likely than they would have been, more likely than someone else is, to use violence or, sorry, I just bumped into my coffee cup, to use violence or to be victimized again. And so we can see at this individual level even the ways that cycles and past experiences are contributing to future outcomes. So you may know about, some of you may be working on individual level interventions that are focused on interrupting that cycle. An example that I like to give that we're working on here at BU is in partnership with the Violence Intervention and Advocacy Program at Boston Medical Center. It's one of the oldest hospital-based violence intervention programs, HVIPs, in the country. And the idea is that when someone has been violently injured, you all may be familiar with this. When someone has been violently injured, they show up in the hospital with a violent penetrating injury. They are someone from this program who is typically a credible messenger, meaning someone who has some shared lived experience of either violent victimization, living in the same neighborhood, sort of exposure to violence, reaches out to that person while they're in the hospital to establish a relationship. And that's a relationship that sort of follows the person past when they're released from the hospital, and within the context of that relationship, the HVIP worker can help the injured person navigate medical care, but then help them navigate follow-up services they may need from a health standpoint, and also address some of the social needs that they face, often some of which might have contributed to their risk of being victimized in the first place, including housing instability, lack of employment, lack of educational opportunities, and issues like that. And so there is, at the moment, these are being widely used. I would say, has reached the level of standard of care for, in part because it's so widespread that folks have unmet needs. At the moment, there's still some gaps in the evidence base around whether this is effective at the individual level, specifically for preventing re-injury or use of violence downstream. But that is the idea. The idea is that when someone has been injured, they call this a teachable moment, when they may be more receptive to services. And one reason that HVIPs are being posed as a community violence intervention, meaning prevention intervention, is that helping someone navigate these systems and address social determinants could reduce their risk of being re-victimized or enacting violence against someone else in the future. So that's not the only purpose of these programs, but it is a big part of the conversation as we talk about scaling up community violence intervention at the national level. So we're going to go forward on the assumption that one prominent HVIP goal is violence prevention. So we're working on that evidence gap. We have an ongoing, we're doing an analysis, turns out to be pretty complicated, but an analysis of the effectiveness of VIAP at reducing and improving individual level violence outcomes after intervention. But the way we're thinking about this, part of why this matters so much, is that there's an opportunity, we think, for this intervention, if it's effective at the individual level, to produce population level benefits. So this is the first study I'm going to talk to you about. Conceptually, the idea is that if this is not just about breaking those individual level cycles, because as we look upward in a social ecological model where individuals are at the bottom and they're sort of thinking outwards in their social space into their relationships, their contagion occurs. So the idea that if I have been victimized, I may be more likely to use violence, possibly in retaliation against the person or the people who harmed me, or possibly just through reenactment of this harm. Maybe I'll be more likely to carry a weapon because I feel unsafe. Maybe I feel like I need to save face. But the idea is that this creates a possible sort of transmission of violence from me as a victim to a survivor, to others who are sort of near me in my social network. So here's a very simple diagram of how this could work. Is the idea that once you come in and you've been injured, once I've been injured, my risk of using violence increases. That's going back to Dr. Carter's study. And now I can spread it to others. However, if I engage with a hospital-based violence intervention program, my risk of spreading violence could decrease. And so now, instead of being someone who's sort of possibly an outward transmission vector, now I'm a safer person. And so we hypothesized that this could produce population level effects. And this is important. So just stepping back, I think when we saw those huge disparities in gun victimization and extremely high rates of the extremely high burden of gun violence among youth and others, we're looking for opportunities to change this patterning, not just at the individual level, but at the population level. There's sort of, I think our mindset can sometimes be a little different from our colleagues working specifically in the community violence intervention space, because it's so easy to see the individuals who need access to services and opportunities and other kinds of response because of their own experiences. And I think as public health professionals, public health thinkers, we also need to see this problem and think this patterning is unacceptable, and we need to be finding ways to address this at the population level. So that's why we're sort of motivated in a case like this of HVIP to say, like, yes, it's incredibly important that these individuals coming through the hospital get these services they need. And let's think about what it might mean for how this intervention could translate to the population level, not just the set of specific individuals who you're able to serve. I'm going to pause there in case there's questions with this framing. Okay. So agent-based models. So the way this is the first of two computational approaches that I'm going to talk about today. And so the idea is that what we want to do is to try to understand how this process might work, how cooling down risk in individuals who've been injured could benefit populations, could make populations safer, rather than enabling this process of transmission, where in the case where, sort of unacceptably, people do not get the kind of services that they need post-injury. And so we're going to use agent-based models. This is a computer simulation model. You could think of it as kind of a simple video game, not to trivialize the problem that we're working on, but just in terms of the environment that we're creating, where there are entities who represent people, and they can have traits, they can be located somewhere in space, they can have experiences that accumulate over time. And what we can do is we can use this to kind of give a rough idea of how processes work and what kinds of outcomes might arise. And the big challenge here is just sort of creating a simulated computational world that is accurate enough, that includes enough of the right characteristics that it can sort of replicate real world processes, predict what might happen under different circumstances when you change things. So we're going to conduct an experiment here. And this is work with Jason Goldstick from Michigan. So in this computer model, we are programming our population to look like the population of Boston's youth, a 5% sample. Everyone gets an age there, and everyone has a level of risk, a propensity to have some violence involvement. Risk is in the model is associated with age in a realistic way. Risk is concentrated in a very small subset of individuals in a realistic way. And we're going to include this process where either once you've been injured, which happens in a sort of in a way that's kind of semi-random, but once you've been injured, if you have been, then your risk increases. And if instead, if you get the HVIP services because you were in the right catchment area and you accepted those services, then your risk decreases. And so we're going to, again, make this realistic by having a realistic case fatality rate from shootings, having an increase in risk associated with a previous violent injury. This is, again, from Rebecca Cunningham's work from Flint. And those age-specific risks. We also have data specifically from the Boston HVIP program. That's the uptake, sort of the proportion of people who accept services once the person walks into the room. 70, a catchment area. Not everyone who gets violently injured in Boston comes to this one hospital, but most do. And we're going to hypothesize an effectiveness of 50%, although we can test sensitivity to that. And so then what we do is we have this world and we just let it run. So it runs many times. We're going to account in that way for some of the randomness that comes into play. But basically, we can see what happens when you either have this HVIP or you don't have it. And that's something that no study has ever really been able to give a good estimate of what's the difference in gun violence rates citywide, depending on whether you have this HVIP or you don't. Some studies have tried to estimate what's the effect of the HVIP on an individual person, but no one has tried to estimate it at the population level based on what we're including here, which is the idea that people can transmit once they've been injured. If their risk goes up, now they can transmit to other people by being involved in violence. So we're going to run simulations that test that process. So compared to this scenario, we run it 200 times without the HVIP to get a baseline, and then we run it 200 times with an HVIP to get a range of outcomes. So on average, having the HVIP reduced the injury rate by almost 7% over a 21-year study period. But it takes a while for that effect to emerge. So in the second half, the reduction is more like 8%. In the first half, it's more like 5.5%. And there's no effect visible at the population level for the first 5 years. So you see the curve kind of bending downward. That's consistent with what we see for other population level interventions that basically sort of like vaccinate people against disease is sort of a loading effect. And so that's what happens here in this study. And this is consequential for policy because there have been more and more experiments in funding and starting up new HVIP programs. And around year 4, year 5, the policymakers come in and say, like, hey, how effective was this big investment we made? Is this working to prevent gun violence in the city? And sometimes it's not possible to see an effect. And so this simulation shows you that you should not expect that effect so soon. Even if it's working at the individual level, the citywide effects won't be visible for more than 5 years. But if you let them accumulate, they can be substantial. And substantial, but still we estimate below 10%. And so we need to look beyond individual level interventions alone. Any questions on that one?
I have a quick question. Is this data that you're using, you mentioned Patrick Carter, is this from Detroit? Is this real world data from Detroit?
The estimate of the proportion increase, the risk increase, that comes from a study from from Flint. The parameter estimate that we used was from a 2015 study with data from Flint.
Okay, thanks.
And I see a hand raised from Calvin Evans.
Hello, Jonathan. How are you doing?
Good, how are you?
I'm great. So I'm very, very, very familiar with HVIP programs. In fact, I co-founded the first hospital-based violence intervention program in the state of Michigan at the #1 hospital for penetrating trauma, which happened to be Sinai Grace Hospital in Detroit. We began in 2016, and from 2016 to 2018, we had 50 participants. And the study reflects from Philadelphia, from across the country, in HVIP work, the study reflects that if you're violently injured, there's a 45% likelihood that you'll be re-injured again, which you accurately pointed out. And this is all about whether does the individual model work or not, and how we can acquire the data to fill in the gaps to say that it do actually work, right? I would be considered a credible messenger or a violence intervention specialist of sorts. I did this work for 7 years. In fact, I have a young man who came through the hospital on the phone now that was on my census. His name is Antoine Green. So when we're talking about a 5-year period, and we're talking about understanding, the whole structure of the social ecological model from an individual level and how it affects on a population level, and how important people who have been impacted by these things, voices are necessary, and how we organize them to lead conversation. What takes place in Boston, in fact, I know some of the people on the picture. In fact, I trained some of those people. So before, with the hospital-based violence intervention, it was a national network on hospital-based violence intervention program. And actually, D-Live led the work for HVIPs, and so I'm saying that to say we got some great data in Detroit. And I love what it is that you're doing. And I'm proud that this information is coming out so that we can fill in the gaps. There's funding right now, CVI funding, that is being garnered in our states, which you'll probably talk about. I don't want to take over your presentation. Good job, but the individual level do work, and there's evidence. There's data that we can research to prove that it does work. I don't think we looked at the data yet, though. And that's just a point that I want to point out. And I'm here as a victim of violence, came through the hospital as a credible messenger, have a young man who came through the hospital doing great works, as a community health worker at the Detroit Health Department. It do work. So thank you for your presentation too. Anything you need me, you want to reach out to me, we can go through what Detroit has done and is doing. I promise you it's working. Thank you.
Thank you so much, Calvin. I really appreciate everything you shared, and thank you for your work in the space. I would love to follow up with you. Just to say a little bit more about what we're doing with the program in Boston. They have collected many years of data on outcomes, sort of whether the amount of services that folks received from them, and then their violence-related outcomes over the following years. So we're doing a quantitative analysis of sort of the effectiveness of the program for improving those violence-related outcomes. And we're also doing a qualitative study with folks who have, because this program's been going on for so long, folks who were injured at least 5 years ago and either did or didn't engage with the program, to get an idea of both sort of the role that the program did or might have played in their lives, but also what were the long-term determinants of their outcomes. And so sort of trying to understand how this program can fit into the arc of individuals' lives. But, again, this is just the Boston example. And so, yeah, I'd love to talk and learn more about the Detroit example. Ooh, okay. So there's a question about AI. The next study uses machine learning in a way that might be relevant to this question. So maybe we could come back to the AI and machine learning questions at the end. And then Lainey's question about qual or quant or both. The first study is quant. The second study with survivors is qual. I think.
Oh, I meant that when you followed up with the folks who've been injured 5 years ago, was that interviews or was that surveys?
We haven't done that yet.
Okay, great. Okay, it's
That's
coming
the
up.
second. That's sort of like step 2 of this grant.
Okay, great.
And that'll all be interviews.
Cool.
Okay, so I'm going to run quickly through sort of why the study is not specifically on place-based strategy. So I'm going to guess that a lot of you are familiar, given where you're at, a lot of you will be familiar with this research. This is on, so, sort of everything that we see in all of the individuals and relationships we see are nested within community contexts. And so this is a picture from Philadelphia. Folks have told researchers like living near a vacant lot that looks like this makes you feel unsafe. You can't go outside. This is a photo voice project from Pittsburgh where young people told the researchers that when you see abandoned buildings in your neighborhood, it makes you feel like no one cares about you and your community. And so there's this idea that feeling unsafe in your community, this is one more way that cycles are reinforced. If many people in the community feel unsafe going outside, getting to know their neighbors, that makes a neighborhood where violence has happened continue to be susceptible to violence because of sort of now there's a loss of collective efficacy and other healthy social processes. So you call that a feedback loop. This is the result of turning vacant lots into small green pocket parks was associated with reductions in gun violence in Philadelphia and also in Flint. And some of my work, including my postdoc work with the FACTS Consortium, we found that abandoned building demolitions can be associated with reductions in gun violence. That's using data both from Detroit in one study and Rochester, New York in another study. There are certain caveats to the demolitions because that's not always the best or the most desired intervention by folks who live in neighborhoods that have a lot of vacant buildings, but in some cases it is, and our results suggest that demolitions may reduce community violence. One reason that these strategies work, according to Laney and Mark Zimmerman and others at Michigan, is explained by busy streets theory, the idea that safe physical spaces, vibrant neighborhood spaces can foster positive social processes that, among other things, reduce violence. Is that a fair characterization of that, Laney?
Yeah, and I think specifically, I always think of it also as involving community in making environmental change is another way that busy streets can facilitate safety. So not only do like safer, more orderly environments make people feel safer, but when they are engaged in improving them, that can kind of even further create that upward spiral of neighbors feeling connected and having social resources to keep their neighborhood safe. That's how I explain it.
That's really good. So not just an outcome, but also a process. So the way we get there matters. One thing that we're doing in Boston right now is working with schools to understand safety at the interface of school, sort of the school buildings and the community spaces outside. And so I think just setting that up, we can understand that the distribution of vacant lots, abandoned buildings, those are contributing to racial disparities in gun violence, right? It's not these disinvested spaces are not clustered in affluent white neighborhoods, right? They are associated with a number of other dimensions of social deprivation. And so that forces us to look further up in the social ecological model to the societal forces that shape community level exposures. And so here we're going to conceptualize these as segregation and disinvestment. Residential racial segregation is a fundamental cause of health disparities. You'll see some research that thinks about segregation as kind of a proxy for structural racism, but David Williams and colleagues would propose that segregation is not just another dimension of racism, it's one that enables others. Right, so think about among the inequities that are assigned based on race in the US, like what are some examples of really important factors that are patterned on race, but rely on segregation in order to exist? Facially neutral, not assigned in discriminatory ways, at least on paper, but they're assigned, but in fact, we see inequities because of segregation. Oops, sorry. Home ownership, food deserts. So food deserts, for example, it's like if we had some neighborhoods that have healthy food options and some that don't, but we had no segregation, right? Then there would be no inequities in access to food, but we know there are. Pollution, really good example, environmental injustice, right? Again, those create inequitable exposures, but only because residential contexts and other contexts are racially segregated. Healthcare access. We're going to talk about redlining a lot in just a second. Schools feels to me like kind of one of the classic examples. Like access to quality education is just so foundational to health in various ways, but also the reason, like the current system that we have for creating inequitable educational contexts, the most important thing is residential segregation, right? If where you live determines what school you're assigned to, and property taxes pay for all the resources that the school needs, then the affluent white community gets better schools for affluent white kids. Okay, so thinking about segregation is fundamental, not just another dimension of structural racism. And here's an example. You can find these dot maps for every US city. Boston is one of the more racially segregated cities in the US, but the Northeast and the Midwest are display the most extreme residential racial segregation within cities. And so, if you look at Detroit, for example, maybe less of that racial segregation is happening within the cities versus like city versus suburbs. But this pattern, whether you need to zoom in or zoom out a little bit, you're going to see these really stark patterns in every metro area, especially in the Northeast and Midwest. And Milwaukee is a very good one. And so just so we know, we're talking about redlining. So this was a federal policy that created the Homeowners Loan Corporation, which starting in the 1930s graded neighborhoods on a scale of A to D, with A being the most favorable grade and D being the most unfavorable grade. And banks used those grades to determine whether to give people mortgages. The federal government would back mortgages in the higher graded neighborhoods. And those grades were assigned primarily based on racial composition. So especially Black population and other racially minoritized identities at the time, which included Italian and Irish. And so it reinforced segregation, and it reinforced the concentration of resources in white neighborhoods. So we know that these this policies from the 1930s are associated with present day inequities in the environment. And that could be in part because of the ways that environmental characteristics are shaped over time. Like since the 1930s, it's going to take a long time period like that to create inequities in tree canopy and alcohol outlets and others. So some of these other factors that are really important. I'm going to speed up a little bit to make sure we have plenty of time for Q&A. So what we're trying to do in this study is to create a measure that picks up not just, I'm sure some of you have seen measures of like acute physical disorder, like is there trash on the ground? Is there graffiti on the streets? This is something that actually the Prevention Center collects for Flint and Youngstown and other cities. That's a really important dimension of environmental inequity. But we think that we can also zoom out to see these longer term patterns of, you know, what does the housing density look like in this neighborhood, even before we look for, you know, whether there's trash on the ground. So the idea of the study is to create a measure that encodes the association between redlining in the 1930s and the present day built environment. There's the computational part. Here's the machine learning part, for those of you who get excited about this kind of thing. So for the city of Philadelphia, we took the redlining map and we imposed it over a very small grid. These are 500 by 500 meter squares. Then we're going to take an aerial image from the present day. These are like 2019, 2020 aerial photographs. And we're going to pass them through a computer vision model. So this is like, if you think about the algorithms that allow you to search Google Photos for pictures of your dog, those are models that are designed to just take a picture as an input and assign a label that's like, that says dog. So we don't quite want that. But what those models have done is they've been trained on millions of images to figure out like what are the combinations of pixels that are relevant to different kinds of identifying objects. So we're going to kind of hack that algorithm to pull out data from the photographs that we can plug into another model. So it's going to tell us about something about the arrangement of the built environment, of green space, streets, other sort of aspects. It's not going to identify them for us, but it will give us machine readable data. Then we're going to use that to try and predict the 1930s whole grade based on present day patterns. So the idea is if we can, we're trying to train the algorithm to see what a place that was graded A, what that looks like today, and what a place that was graded as a D looks like today, on the hypothesis that over time, the lower graded places saw disinvestment. And so if a place looks like it got a D in the 1930s, that means that it's disinvested today. If it looks like it got an A in the 1930s, that means it's gotten investment since then. So this is racialized disinvestment, okay? Here's the results. This is what the model thinks. It thinks that these are places, that this is what a place that got a good grade in the 1930s looks like today. What stands out to you in these photographs? Like how would you, if you had to describe these photos to someone, like what are these, what are the characteristics of these places? Lots of tree cover, lots of green space. Yeah, the trees definitely stand out to me too. As you go from A to B, you're starting to see more buildings and more roads. If you find that noticeable, just wait. Yeah, B looks a little more industrial. Yeah, okay, so interpreting the trees, like why the trees matter. Trees creates shade, which is important, especially in hotter weather. There's also research on the association between trees and more trees, less gun violence. Yeah, we can't necessarily see people's yards because there's so many trees, but we're gonna guess that because there's so many fewer buildings that there are larger yards. Like maybe in a pandemic, your child can hang out in the yard. Okay, here's what the model thinks that C and D grades look like today. What stands out to you from these images? Yeah, a lot of buildings, a lot of roofs. Yeah, and then right, you can see spaces that look like they're probably parking lots, like just a lot of paved over spaces that may not be buildings. Parking lot, maybe not a big community asset. So little green space. And you can see patches of spaces that could be green, but seemingly aren't. Between A and D, which do you think just intuitively is more conducive to gun violence? I'm not going to wait for you to answer, but thank you. Yes, thank you. I mean, I think that's consistent with the research, and to me, I think the sort of intuitive feeling. And so, but we tested this. So, well, first we validated this against other measures of disinvestment, like vacant lots, tree canopy, sort of some of those measures, and found that it has the expected relationship with those other measures. And then we analyzed gun violence, and we found that compared to a place that the model thinks was a place that the model thinks was a D, is associated with 40 times increase in shootings rate. And you might think, okay, that's confounded by a lot of things. After controlling for everything we could possibly, these are fatal and non-fatal shootings from Philadelphia police data. After controlling for everything we could possibly think of, including residual spatial autocorrelation, there's still more than a doubling of risk associated with the predicted score. And interestingly, the predicted score predicts shootings better than the actual redlining score. So that might tend to suggest that it's picking up something more important. Yeah, Kate, go ahead.
Okay, I think you just touched on this a little bit, but you said the predicted Hulk score versus the actual Hulk score. So are you saying that you used like redlining maps to overlay them over your firearms violence spatial data first, and then
sorry, these slides don't have as much detail as they should. Yeah, so we turned the whole city into this grid. And we only used areas that had gotten a redlining grade. This is part of why we use Philadelphia, is that a lot of Philadelphia was graded. And so then we used these as the units of analysis, which we paired with the fatal and non-fatal shootings data.
Wow. Okay. This is so cool. Thanks.
Thanks. So yes, and the predicted scores were associated with the actual scores at I think around 0.6 correlation coefficient, which is kind of what we want. It's like it's a good prediction, but there is still some difference. There obviously some places don't look like the score that they actually got. So, and this turns out to predict a bit better. So, I think it's important to understand how gun violence, including these huge racial disparities that we see, are happening under conditions that are shaped by historical and ongoing policy decisions. And a really important one is physical disinvestment from neighborhoods. There are many other examples like mass incarceration, child poverty, and these are, and one reason why disinvestment is of so much interest is because it's directly linked to the neighborhood conditions that are modifiable. So fixing vacant lots, fixing abandoned buildings, disinvestment can be reversed through investment. So just very quickly, we did a study with the VIAP data looking at post-injury outcomes. If you go home from the hospital to a neighborhood with greater racialized economic deprivation, you're more likely to subsequently be arrested for using violence. So that suggests that, sort of independent of how effective the HVIP can be, there are conditions outside in the community that are shaping the risk that people experience. I think that's pretty intuitive, but we were even able to see it among people who had already shown up in the hospital with a violent related injury. And so it just goes to show sort of how much those neighborhood conditions are contributing, even within a population of people who've already been injured. And so it points to, I think, important questions, which is, can we be doing HVIP in a way that's better aligned with place-based interventions? Can we be doing place-based interventions in a way that's better aligned with community violence interventions, including HVIPs? Because the problems themselves are intertwined. And similarly, as we work upwards, can we be aligning this with policy advocacy and in a way, community leadership in ways that can meaningfully change structural conditions? I've left a few minutes for questions. I'm happy to, if anyone can stay on longer, I'm also happy to stay on and answer more questions.